musculoskeletal conditions, leading cause of disability, as we have seen, point prevalence that 18% of population all over the world is suffering is from low back pain. It could be multiple reasons, but low back pain could be there. Acute low back pain up to 4 to 6 weeks. The different guidelines from various centers, they from 4 weeks to 6 weeks they say about acute low back pain. Subacute low back pain from 6 weeks to 6 months they say. Chronic low back pain more than 6 months. So coming to directly to the main crux of the topic. So what if the patient, we have seen the patient, now what are the medicines which we can prescribe in such patients? So the common medicines which is being prescribed is the NSAIDs, that is a non-steroidal anti-inflammatory drugs, especially that diclofenac, aceclofenac, which is specifically being and very commonly prescribed in these conditions. They act upon COX-1, COX-2 receptors and they reduce the inflammation and help in pain relief. Etonecoxib, that is the COX-2 inhibitors, now polmacoxib has also come. So these have COX inhibitors, they have very good evidence in treating the inflammation and reducing the pain. Next is paracetamol or acetaminophen. We can give from 1 gram to 2 gram normal dose, and it can be increased to 3 to 4 gram daily. And there are multiple studies you can find online that paracetamol is very effective in cases of treating low back pain. Opioids. In opioids, we usually use the weak opioid, that is the tramadol and tapentadol commonly. If the patient is not having adequate pain relief with the NSAIDs, then we use this tramadol and tapentadol. Starting dose is from 37.5 mg that we see in ultraset combination, and it could be increased up to 100 mg BD, TDS, and 420 also. Tapentadol starts from 50 mg OD, BD, or it can be increased to 200 milligram also. So and next is strong opioids. Strong opioids are usually not recommended in treating the low back pain cases. The reason being is that if the patient is not having the particular pain relief with the weak opioids, NSAIDs, and all those combinations, then prescribing strong opioids will never have an adequate effect. Then we should identify the pain generator that is causing the pain and treat it accordingly. But without treating the actual cause, and we are just giving the pain as strong opioids, there is a risk of addiction is there. There is a risk of, if we see the benefit to risk ratio is low in cases of strong opioids, so there are contraindicated in most of the guidelines. If we see the muscle relaxants, it is also have some controversial role. Some guidelines they support their use, short-term use in cases of acute low back pain for 2 to 4 days, and other guidelines they don't support its use. Benzodiazepine like diazepam and all those things, they are not recommended for in these low back pain cases. For non-benzodiazepine, centrally acting antispasmodic muscle relaxant, that is the cyclobenzaprine, tolpedicine, and metazolone. These are the muscle relaxants which are being used in cases of low back pain. For short duration, we can use peripherally acting antispastic which act upon neuromuscular junction, that is the baclofen and tizanidine. They can also be used for reducing the muscle spasm for short duration in low back pain cases. Antidepressants, if we see, that is the tricyclic antidepressants which act upon serotonin and norepinephrine reuptake inhibitors. These are used specifically for like amitriptyline and nortriptyline. They can be used for neuropathic pain with some associated symptoms like sleep disturbance and little bit anxiety and all those things. They can be used. Anticonvulsant, that is the gabapentin and pregabalin, they act upon voltage-gated calcium channels and they help in reducing the neuropathic pain. So in initial neuropathic pain, they can be used. Gabapentin can be started from the 100 milligram HS and it has to be graduated upwards. And it usually the maximum dose which we are usually seen for in these cases is 300 TDS, that is 900 to 1200 milligram can be given in a day. If the pain is still there, then it means that you are not able to treat it properly and you should go for intervention. Pregabalin, we can start from 50 milligram, that is available in India right now. So from 50 milligram, we can titrate it up to the 150 milligram. Indian patients usually tolerate up to 150 milligram. Systemic steroids, we see a lot of prescriptions from orthopedicians and neurologists that they are giving IV or IM steroids or oral steroids also but all the evidence is against it. So there is no use for it. They say that the from personal experience that they reduce the inflammation, all those things. So short-term benefit could be seen, but evidence is against it. Management of comorbidities. Most of the guidelines they suggest that the comorbidities like diabetes, hypertension, control of anxiety and sleeplessness should be always be there. Multidisciplinary, multimodal care should be given in these cases. There are multiple articles, if you see, which suggest the use of herbal medicines like boswellia, devil's claw, turmeric, and all those things. There are some little bit literature reports, cases, and all those things are there. So in some guidelines, they support their use, but actually, the lot of RCTs needs to be done for these things. Now coming to local treatment. So what all the can be done? So hot packs are preferable over ice packs if we see for the low back pain cases. So because ice packs, the penetration of the cold effect is very low. So in hot packs is preferable in case of low back pain cases. Coming to topical analgesics, counter-irritant ointment gels like diclofenac gel, ketoprofen gel, methyl salicylate, menthol, and capsaicin, they act locally and they help in reducing the localized pain. Patches, if we see lignocaine patches are available, ketoprofen patches are available, and they have very good evidence in treatment of local low back pain. Massage. So massage has some inconclusive evidence. Some studies show good effects, some refute their effectiveness. But overall, if you see in most of the guidelines, they are effective. They show that they are effective for subacute and chronic low back pain. Coming to acupuncture and acupressure, there are multiple acupoints in the body, and there are multiple literature from, especially from Southeast Asia, China, and all those countries that these things help in reducing the low back pain. And there are multiple RCTs have been published, and all those guidelines are there. Now coming to rehabilitation, the most favorable modality which has been talked about in all the evidence is the therapeutic exercise. So therapeutic exercise is different from normal exercises. That in therapeutic exercise we are first of all seeing what biomechanical disability or biomechanical error is there, and we are prescribing the exercises according to treat it. For example, in cases of acute herniated lumbar disc, we are promoting the little bit of spinal extension. We are avoiding the spinal flexion activities. In cases of facet joint problem or lumbar canal stenosis, we are promoting the spinal flexion. So this is the thing which we should know what actually what all exercises should be prescribed. Spinal manipulation, that is a quick control thrust that is we are seeing by the chiropractors, and spinal mobilization, that slow repetitive joint movement. These are two modalities are suggested in many literature articles, and they are suggested for treatment of subacute to chronic low back pain. Progressive muscle relaxation, in this the patient is asked to gradually relax his muscles by controlling his thoughts and all those things, and a little bit stretching exercises being done. So this has also been shown effective in multiple articles. Multidisciplinary treatment, as we have discussed. Lumbar supports, if we see, there is a limited evidence, but it is also inconclusive evidence is also there. If we see difference between the soft support like simple lumbosacral belt or the contured with steel stirrups are there. So the rigid is always better in cases of that because it provides a greater support to the lumbosacral spine. But the problem is the poor compliance with the patient. Complementary movement therapies like yoga, Alexander techniques, pilates, and Feldenkrais method are all been discussed in multiple articles published from various countries. Physical modalities, if we see, the TENS has little evidence in that, but whatever the little evidence is there, it is a very good positive evidence. So short-term relief, or we can use the TENS. Low-level laser therapy, that is the class 3 lasers, they have been shown as a fibroblastic reaction. Fibroblast proliferation is there, and it induces the healing response. Anti-inflammatory effect is there. So laser therapy is being popularized in many centers. Short-wave diathermy, interferential therapy, electrical muscle stimulation of the weak muscles has a good effect. Traction, if we see, it is not more effective than the placebo, so it is nowadays contraindicated. Lifestyle changes, if we see, bed rest, if we see, the bed rest is not recommended for more than 4 to 5 days. So in cases of subacute or chronic low back pain, it is completely contraindicated. But in case of acute low back pain, we can prescribe it. Staying active is one of the most important intervention which has been favorably reported in most of the articles. So the patient should stay active as possible. He should not take long rest or long sitting or long standing position. Self-management, that the patient should take the charge of his health by himself or herself. He should not take more passive therapies like physiotherapy and all those things, physiotherapy. So he should focus that he should take care or take charge of his own health. Returning to work, because what happens when the patient is having low back pain, he tries to stay at home, tries to avoid his work, and the absenteeism, leaves, and all these things. But if he returns to his work, then it has shown very good results. Postural therapy, that correction of posture, sitting posture, standing posture, lifting posture, bending posture, all these things has to be taken care of, and it has shown a very good effect. Coming to back screws, there are multiple back screws operated in the US, Canada, and the European countries, in which they focus on patient education and counseling, exercise training, postural correction, and psychosocial training. So they have shown a good evidence in multiple articles. Psychological treatment, the reassurance of the patient that he or she is not suffering from very grave disease, he will not die for that with that disease. So reassurance is important. Fear avoiding belief training, that you should try to avoid that fear of movement, that is a kinesiophobia. Okay, so we can do this by the graded exposure of that particular movement. We should address the misconception that this movement will increase the pain, encourage the activity of the patient. So these are the things we do in this thing. Cognitive behavioral therapy, we have to identify and challenge the negative thoughts, which is increasing the pain, developing the coping skills, coping mechanism against this pain. Behavioral activation, that he should think positively about his pain and he should not succumb to the negative thoughts. Set realistic and achievable goals. According to the stage of the disease, we should set a realistic goal, that we should not progress too fast or too slow in these cases. Mindfulness-based stress reduction, this MBSR is a very reputed technique for reducing the pain. In this, the patient is always mindful about what he is doing, how he is breathing, how he is moving or movement, walking, and all these things he should be taking care of. All these things have shown good evidence. Now, if we see the guidelines, I call it game of guidelines, because every 6 months to 1 year you will see a new guideline coming from different part of the world. So first low back pain guidelines were published in 1987 by Quebec Task Force. After that, till now, there are 22 common practice guidelines have been issued from 15 countries and regions. Even African guidelines are also there. Okay, so there are multiple guidelines all over from the world. So from various countries, various professional associations, from neurologists, neurosurgeons, orthopedic surgeons, physiotherapists, this occupational therapists, psychologists, all these multiple guidelines are there. So there is a very diversity and heterogeneity of guidelines is there, which is very difficult to assess what actually works and what actually doesn't work. Also, there is insufficient evidence. So most of the what are the modalities we have talked till now, so there's insufficient evidence about that. There's a lack of proper RCTs with comparison of different modalities. What actually is working, what actually is not working. So it is very difficult to assess. Also, there's a regional variation, that some things are more promoted in China, that is the Tai Chi and acupressure practice more commonly in Chinese countries and South Asia countries. In the US, chiropractors, spinal mobilization, spinal manipulation are more favored. So it is very difficult to see. Confounding factors there are so many. So in this, it is very difficult to assess. So if we can see, there's a US Preventive Service Task Force guidelines are there. We can see NICE guidelines are also there. Canadian guidelines are also very famous. If we see North American Spine Society guidelines are also there. American College of Physicians guidelines are also there, and WHO guidelines are there. So if you go through all those guidelines, still you will be confused. Okay, so I have got through one good article which has been published in 2024, BMC musculoskeletal disorder. It has compared clinical practice guidelines from various countries. So if we see the common what the summarize it is summarized that in acute low back pain, subacute low back pain, or whether it is a chronic low back pain, or in all the three things, NSAIDs, therapeutic exercise, staying active, and some part of spinal manipulation or acupuncture works. If we compare all the guidelines, so if we see in this the acute low back pain, if we see in this acute low back pain, we can see multiple these graphs are there. We can see the agreement. The blue ones are the agreement. The most of the guidelines are in agreement with a particular treatment modality. This red one is the disagreement, green is the no evidence, and the violet one is not mentioned. So if we see most of the guidelines, they don't compare many of the treatment modalities, but staying active, self-management, therapeutic exercise, heat therapy, acupuncture, spinal manipulation, spinal mobilization, massage, NSAIDs, acetaminophen, opioids, and muscle relaxants, they have very good agreement in most of the guidelines. If we see from the subacute low back pain, all these things are nearly the same, and if we see in the chronic low back pain, most of these things are same. So reassurance and mindfulness based stress reduction, cognitive behavioral therapy, progressive muscle relaxation, these are the same. So to summarize whatever in these things, so new guidelines come up every year, every 6 months from different parts of the world. So these guidelines come from different articles which are being published, some RCTs are being done. Every area of the world supports its own treatment modality. Okay, so we can't rely on any one guidelines. There regional differences are being there. Medicines should, so what should we do? We should prescribe medicines according to the symptomatology or possible pain generator. Regular therapeutic exercises targeted according to the biomechanics of the should be prescribed. Staying active is important. Regular posture change is important. And last is stress and fear of movement avoidance should be there. This is all how I summarize this.